Dr. ROOPASREE.
Good afternoon. I am going to present on the topic evaluation of Descemet's membrane detachment based on anterior segment OCT in manual small incision cataract surgeries. No financial disclosures, ethics committee approval was obtained. DMD is an important cause of surgery-related corneal edema that may lead to corneal decompensation. When and how to intervene for DMD has been an area of controversy because the progression and the natural history are still unclear. The incidence in ECC is around 2% and 0.5 in FACO. Dua's classification of DMD goes like this, with type 1, 2, 3. In one, separation of PDL and DM, but they remain attached together. And type 2 is only DM is detached, and in type 3, PDL and DM are detached, but separated from each other. These are some images showing types of DMDs according to Dua's classification. Our aims were to evaluate DMD based on AIOS2025 in manual small incision cataract surgeries and to study the risk factors and morphology of DMD based on Dua's classification. Patients who underwent MSICS in our hospital found to have DMD during postoperative evaluation were in the source of data. They were taken from Jan 23 to December 23. It was a prospective cross-sectional study. Sample size came to be 31. The data analysis was done with different statistical methods, and p-value less than 0.05 was considered statistically significant. Patients aged 18 and above of either sex who have undergone MSICS and diagnosed to have DMD in AIOS2025 during postoperative evaluation were included in our study, and any corneal pathology and ocular comorbidities were excluded. Preoperative detailed evaluation was done with all the tests, and the grading of nucleus as per LOCS3 system and the amount of mydriasis was noted. Fundus examination and IOL calculation was done. Postoperatively also all the tests were done in detail, and AIOS2025 evaluation was done in all cases with striate keratopathy and corneal edema. Patient details were entered in the system, and DMD was classified according to Dua's classification. We divided the cornea into 4 quadrants by imaginary horizontal and vertical lines, and 2 or more quadrant involvement by DMD was considered as multi-quadrant DMD. Coming to the results, total 31 eyes of 31 patients were included. Mean age was 67 years. Among them, 80% were females, and maximum number of eyes were in the age group of 60 to 70 years. Out of 31 eyes post-op, they had uncorrected vision less than 6/60. Maximum number of eyes had mature cataracts followed by NS2, and maximum number of eyes had good pupillary dilatation of 8 mm. Types of DMD among 31, 29 eyes had type 2, type 1 and 3 were seen in each, 1 eye each. Out of 31, PCIOL was implanted in 26 eyes, and 4 were left aphakic because of intraoperative complications, and iris claw was implanted in 1 eye. Out of 31, 19 eyes had multi-quadrant DMD, and 17 had DMD involving pupillary axis. Among 29 eyes, type 2 DMD, 24 had severe corneal edema. And among 31, 28 had uncorrected vision less than 6/60. In severe corneal edema cases, the mean height of DMD was 266 and mean pachymetry value was 871. And 26 had linear detachment of DMD and 5 had DMD with tear. And these were some images of type 1, type 2 and type 3 DMDs in postoperative cases. Our statistical analysis showed there was no statistically significant difference in the correlation of multiple variables. Coming to the discussion, our study was on the evaluation of DMD based on AIOS2025. There is a scarcity of data in the literature in the evaluation of DMD based on AIOS2025 using Dua's classification. Ours is a tertiary eye care center wherein large numbers of small incision cataract surgeries are performed. So we chose this study as the results of our study will be definitely helping in the approach towards the management. DMD various patient-related factors which might predispose to DMD are described, which includes age over 65 years. Our study is in accordance with it. We had a female preponderance, and we could not find any specific reason regarding the female preponderance in the literature. And among our patients, pupillary area was involved in 54% of the eyes. Difficult nucleus delivery in soft and harder cataracts may cause DMD. The physiological cleavage plane that exists between the anterior most adhesive zone of DM and the corneal stroma can be disrupted by mechanical forces, suggesting a weak attachment. This may be the probable cause for more number of type 2 DMDs in our case. Determining the type of DMD is very important as it influences the management, because type 1 and mixed DMDs are difficult to reattach, and type 2 is easier to reattach with air or gas tamponade compared to type 1. So to conclude, in our study, AIOS2025 evaluation showed maximum number of eyes had type 2 DMD followed by equal numbers in type 1 and type 3. In our study, DMD was more commonly seen in mature cataracts, older age groups, and female patients. Limitations: it was a cross-sectional study. We could not follow up the patients to know about the further management and prognosis. We could not assess if there was spontaneous reattachment. We would like to recommend AIOS2025 is very essential diagnostic tool in cases of post-op corneal edema to rule out DMD. What our study adds to the literature is, it's different from the other studies as it is based on the Duas classification, which is a recent logical study, and it is based on posterior corneal anatomy. Our study has assessed occurrence of DMD in different grades of cataract, which was not included in other studies. We have also found certain preoperative association for DMD through our study, like age and types of cataract. Thank you. Thank you, sir.
What is the advantage of anterior segment OCT over other clinical methods of detection of vesicous membrane detachment? What is the advantage?
Other clinical methods, yes, sir. This is a non-contact procedure, AIOS2025. How we can see DMD in post-operative cases is, one is slit lamp examination, but if the striate keratopathy is grade 2 and 3, it's very difficult to see the DMD in slit lamp. So in those cases, AIOS2025 can be done. And one more is UBM, but AIOS2025 is non-contact procedure. It is definitely beneficial.
Does what type of SICS is it?
We do.
What is the size of your tunnel?
6 mm.
Okay.
5.5 to 6.
So did you see whether the nucleus was large, whether the technique, why the DMD occurred? So were there any further factors? There could have been many other factors also.
Yes. We studied. There was, as I mentioned, there was statistically significant correlation was not there, but we had many cases of mature cataracts and soft cataracts having DMD.
Okay. Thank you.
Thank you.